The House Oversight Subcommittee on Public Health and Food Security will come to order. Would the clerk please take the attendance?
Chair Beerline.
Here.
Representatives Paquette. Here. Green. McDonald. Here. Cerniglu. Mr. Chair, you have a quorum.
Representative Paquette moves to approve the minutes of the February 24th meeting. Hearing no objection, they are approved. Good afternoon, everyone. I appreciate everyone being here today as we take up an issue that is deeply impacting communities across our state, and that's the closure of in-person pharmacies in Michigan. Today's discussion is not about businesses. It's about access to care. It's about our seniors, about families in rural and urban communities alike who rely on their local pharmacist, not only for prescriptions, but for trusted medical guidance and support. This issue has been brought to my attention repeatedly, and I have heard directly from constituents in my district who are concerned about losing their neighborhood pharmacies. In some cases, the only pharmacy that is serving their community. But these concerns are not isolated. Members of this committee have shared that they, too, are hearing from residents and local pharmacists facing similar challenges. In addition, colleagues from across the legislature representing districts throughout Michigan have raised the same alarm. When a local pharmacy closes, it creates a ripple effect. Patients may have to travel further for medications, experience delays in care, or lose relationships with providers who know their medical history personally. For many communities, particularly in rural areas, this can mean becoming a pharmacy desert. Our goal today, and in the coming weeks, is to better understand the causes behind these closures, the impact on our residents, and what policy solutions may be available to ensure that Michigan residents continue to have reliable, local access to pharmacy services. I'm looking forward to a thoughtful and productive discussion, not just today, but as we continue these hearings. And with that, we'll begin our testimony with Monique Whitney and Brandy Chain representing Pharmacists United for Truth and Transparency. If you'll take the table and then just push the red button when you're ready.
Chairman Beerline, members of the committee, thank you for your time today and for taking the time to examine the role of pharmacy benefit managers that they play with regard to affordable, accessible medication for Michigan patients. My name is Monique Whitney. I am the Executive Director of Pharmacists United for Truth and Transparency, or PUT. PUT is a national 501c3 founded by independent pharmacists dedicated to advocating for fair pharmacy practices, transparent PBM operations, and policies that protect patient access to care. Today, I'll provide an overview of PBMs. The big three PBMs at the center of the prescription drug supply chain, and the next big three who rarely make the news, the way PBMs generate revenue, the relationship PBMs have with pharmacies, the ones they own and the ones they contract with, and how that relationship affects the patient. And then I'll end with some quick observations from 10 years of working with pharmacies to level the playing field between non-PBM owned pharmacies, and some thoughts on enforcing state PBM reform laws. I'm not here today to declare PBMs villains. PBMs can and do provide a real service, but decades of opacity and complexity by design have made it difficult for even the federal government to discern the facts and rein in some of the activities that allow PBMs to reap outsized profits from various questionable but not necessarily illegal business practices. So I'll start with the many roles of pharmacy benefit managers. PBMs are third-party administrators of prescription drug benefits, and put simply, they act as middlemen to drug manufacturers by negotiating better drug prices for their clients' plan formularies, including adding the newest and most innovative medications to formularies and ensuring less expensive but therapeutically equivalent generic drugs are also available. They are middlemen to pharmacies by serving as the claims administrators receiving the pharmacy claims for reimbursement for medications dispensed, and reimbursing pharmacies accordingly. They work with health plan sponsors and plan enrollees, commonly called payers, and then the members. Employers, insurers, and government programs are plan sponsors. PBMs administer plan benefits. They determine whether the drug is covered, at what cost, and at which pharmacy the patient can fill the medication. In all cases, the PBM is also the arbiter of the plan. That means the PBM is the one who approves or denies prior authorizations, decides if a patient must follow a fail first or step therapy protocol, and if a patient must use a specialty pharmacy to fill their medication. They decide how much the patient pays, how much the plan payers pay, and how much the pharmacy will be reimbursed for dispensing medications and counseling patients. As of 2023, PBMs managed pharmacy benefits for approximately 275 million Americans, which is more than 80% of the entire U.S. population. The vast majority of people who fill a prescription using their health insurance are, knowingly or not, routing that transaction through a PBM. The total market these companies oversee is approaching $600 billion annually. The PBMs I'll be discussing today are traditional PBMs. They're distinct from a pass-through or a cost-plus PBM, which are generally thought to be transparent PBMs. Some 90% of all prescriptions are processed through 6 main PBMs, and all of them are traditional model PBMs. So what do I mean when I say traditional model PBM? Traditional PBMs make money by keeping a portion of what flows through them. They profit from the spread between what they charge health plans and what they pay pharmacies. They retain a share of manufacturer rebates, often through their group purchasing organizations or GPOs, and they earn fees that may or may not be disclosed to the client, but are often passed on to pharmacies and their networks, including credentialing fees, which are fees that are charged to join the PBM's network, so-called transaction fees, which is where PBMs charge pharmacies for uploading claims to be paid and then charge them again if they have to resubmit the claim if the claim is rejected. Transaction fees can average in the thousands of dollars per month for some pharmacies. But pharmacies must pay these fees if they want to participate in the PBM's pharmacy network. It's important to understand that traditional PBMs are not fiduciaries. Their financial interests are not aligned with the plan sponsor or the patient, but rather with their shareholders or the shareholders of their parent organization. Years of investigative reporting and studies of publicly available claims data have shown that PBM business practices like negotiating drug rebates lead to higher drug list prices and can lead to larger rebates and larger spreads, which benefits the PBM even as the costs rise for everyone else. So now I'd like to talk about the 6 largest PBMs, and I'll start with that. Right now, according to the National Association of Insurance Commissioners, there are 66 PBMs in operation in the country, but there are 6 who collectively process the 90% of prescriptions I referenced earlier. The 6 dominating PBMs are Express Scripts, which is owned by Cigna Evernorth and holds approximately 30% market share. CVS Caremark, which is owned by CVS Health, who also owns Aetna, with approximately 27% market share. Optum Rx, owned by United Health Group, holds approximately 23% market share. Prime Therapeutics, which is collectively owned by 19 Blue Cross and Blue Shield health plans, holds approximately 5, perhaps 10% market share. But unlike the big 3, Prime Therapeutics is not a for-profit arm of a single corporate parent. It does participate in the same rebate structures and formulary practices as the other PBMs. Humana Pharmacy Solutions at Centerwell is owned by Humana and holds somewhere between 7 to 8% of market share. It primarily serves Humana's large Medicare Advantage and commercial plan membership. And then finally, MedImpact Healthcare Systems, which is the largest privately held PBM. It does not have a major insurer parent, and it holds approximately 4% market share. Together, the top 3, Express Scripts, CVS Caremark, and Optum Rx, control approximately 80% of the market. 5 of the 6 largest PBMs are owned by organizations that also own a major health insurer. That concentration of market power and the conflicts of interest it can create are at the heart of why the PBM reform movement has gained such momentum at the state and federal level. In your packets, I closed a comprehensive chart of vertically integrated PBMs so that you could see for yourself all of their different subsidiaries. I'd now like to talk about PBM services and their revenue streams. And the best way that I can describe this is to go to the Federal Trade Commission's 2024 interim staff report. It did a really good job of summarizing how PBMs serve their clients. So to summarize their summary, the largest PBMs provide plan formulary design. Formularies are the list of drugs that are covered by the health plan. The lists are determined through a process. It considers clinical recommendations, but it also considers the PBM's own business considerations, including drug maker rebates, when to prefer a PBM pharmacy over a local network pharmacy, and the patient, plan, payer, or cost shares for broad, narrowed, and tiered formularies. PBMs maintain multiple formularies per plan, and that is why at times you'll see pharmacies who can dispense the same drug in the same dosage and the same quantity on the same day, and that one medication will be multiply priced according to whatever plan it came from. It's not the pharmacy, it's the formulary, and the formulary is another way of saying plan design. PBMs engage with drug price negotiations with manufacturers, and it was just easier for me to read to you what the FTC said because of the way they described it. PBMs often enter into rebate contracts with drug manufacturers under which the manufacturer provides a payment to the PBMs, which may be largely or entirely passed on to health plans, in exchange for favorable formulary placement of the rebated product, as well as various administrative fees. While PBMs historically negotiated these contracts directly with rebate manufacturers, the big three PBMs recently established separate entities, sometimes called rebate aggregators, to conduct these negotiations on behalf of the affiliated PBMs and their commercial clients. As a result of drug manufacturer rebates, the net prices of drugs to payers are often substantially less than the point of sale prices that determine patient cost sharing and deductibles at the pharmacy counter. The FTC determined that PBMs and drug manufacturers sometimes enter rebate agreements expressly conditioned on excluding generic drugs from coverage. The three PBM GPOs are Ascent Health Services, a Delaware corporation affiliated with Express Scripts and soon to be redomiciled from Switzerland to the U.S. once Express Scripts' settlement with the FTC is finalized. MSR Pharma Services, also a Delaware corporation affiliated with OptumRx and operating primarily out of Ireland. And lastly, Zinc Health Services, which is integrated with CVS Health. As I mentioned, the FTC has described these GPOs as rebate aggregators and concluded that they appear to have been formed specifically to retain revenue from incremental fee structures that do not get passed on to the health plans paying for the benefit, and to insulate revenue from regulatory reform that might otherwise require its disclosure. So also included in your packets, to give you an idea from a manufacturer's point of view what their rebate distribution is, if you look at C&D, you'll see we included a transparency report from Johnson & Johnson, which shows how they distribute their rebates. You'll notice that the highest amount of rebates go to PBMs for the commercial plans. PBMs engage in utilization management, which is drug utilization management services, which control how patients access prescribed medications through policies like prior authorization, step therapy, sometimes called fail-first therapy, and quantity limits, though these practices are often criticized for prioritizing payers' financial interests over patient care. Evidence suggests that PBMs and drug manufacturers sometimes enter agreements that use these policies to discourage patients from using more affordable generic drugs. As I also mentioned previously, PBMs engage in claims processing. It was actually their original role, receiving pharmacy reimbursement claims for dispensed medications and then submitting insurance coverage and payment information to facilitate those reimbursements. And lastly, PBMs do pharmacy network management, which means they build pharmacy networks through contracts that determine reimbursement rates, ranging from open networks to limited or preferred networks, where pharmacies accept lower payments in exchange for higher patient volume. Various studies, including the FTC's, have determined PBMs may manipulate network design to steer patients to their own affiliated pharmacies. So now I'd like to talk about what happens when PBMs own pharmacies. The largest PBMs own pharmacies: retail, mail order, specialty, infusion, and long-term care. It's an often overlooked source of major revenue generation. The FTC's January 2025 report found that the big three PBMs and their affiliated pharmacies generated more than $7.3 billion in excess revenues on specialty generic drugs alone between 2017 and 2022, with markups on some cancer medications exceeding 3,000% above acquisition cost. The most lucrative aspect of PBM pharmacy ownership is specialty pharmacy. In 2023, the FTC found that pharmacies affiliated with the big three received 68% of all specialty drug dispensing revenue in the United States, up from 54% 7 years earlier. Specialty drugs are typically medications for cancer, autoimmune diseases, multiple sclerosis, HIV, and other complex conditions, and can cost tens or even hundreds of thousands of dollars per year per patient. It's important to note that specialty drugs do not require special handling. There's no official designation for what constitutes a specialty drug other than a high price tag. Margins on specialty drugs are generally much higher than on standard retail prescriptions, and that makes them extraordinarily valuable to a PBM. When a PBM both decides which specialty pharmacy a patient must use and owns that pharmacy, that's an intentional design to capture profit at every stage of that transaction. PBMs use their dominance to impose unsustainable contract terms on independent pharmacies, giving them enormous leverage since exclusion from even one major network can cost a pharmacy a significant share of its patients. Independent pharmacies have little ability to push back. Pharmacists have testified before Congress that they cannot meaningfully negotiate any aspect of their PBM contracts. PBMs can further exclude pharmacies through opaque credentialing processes, network denials based on broad and inconsistently applied criteria, even when the pharmacy has no compliance issues. Currently, with limited federal antitrust protections and inconsistent state-level statutes, independent pharmacies have few legal options when shut out of these networks. PBMs use their control over benefit design to steer patients toward their own affiliated pharmacies through tactics like differential cost sharing, which imposes higher out-of-pocket costs at non-affiliated pharmacies, leaving patients to unknowingly choose the PBM-owned option. Some PBM contracts also mandate that patients use mail-order pharmacies for chronic condition medications, effectively eliminating patient choice since the PBM's own mail-order operation is typically the only operation, while actively preventing local pharmacies from offering equivalent terms. For specialty drugs, PBMs further concentrate volume by excluding independent specialty pharmacies from narrow distribution networks, regardless of their clinical qualifications, forcing patients onto in-house platforms. The cumulative result is that patients are systematically redirected away from their preferred pharmacies and toward those that generate profit for the same corporate entity managing their drug benefits. PBM practices affect patients in different ways. Through, as I just mentioned, specialty drug steering, through formulary and coverage barriers. So again, prior authorization step therapy requirements, creating bureaucratic hurdles that delay or deny access to physician-prescribed treatments, forcing patients to fail first on cheaper drugs before receiving the medication their doctor already knows they need, pharmacy deserts, where PBM reimbursement practices are driving independent pharmacy closures, leaving rural, urban, and economically disadvantaged communities without accessible local pharmacy options. And finally, lack of price transparency. Patients are often unaware that cash prices for prescriptions can be cheaper than their insurance copay. And while federal law now prohibits gag clauses in Medicare and Medicaid, protections remain inconsistent across commercial insurance plans state to state. So I'd like to close with a thought, with some observations after having worked with independent pharmacies for the past 10 years on PBM reform. PBMs are sophisticated, well-resourced organizations with substantial legal and lobbying capacity. PBM contracts are deliberately complex. Their business practices are designed to be opaque. Across the country, states that have enacted PBM reform legislation have sometimes found that the legislation, however well-intentioned, has not fully achieved its goals because the enforcement mechanisms were inadequate, the regulatory capacity was underfunded, or the law contained ambiguities that PBMs were able to exploit. And then I'm just going to go off script for a second here and say that having come from Arizona and having watched what's happening in different states, I'm extremely encouraged to hear about Speaker Hall's initiative, the ethics, accountability, and transparency, the HEAT initiative. I think that is a very encouraging movement, and just I'm really happy to hear that that's happening here. That said, I gently encourage this committee to give consideration to meaningful enforcement mechanisms. Strong transparency requirements mean little without a regulator empowered and funded to review the disclosed information and act on it. Pharmacy reimbursement protections mean little if a pharmacy must still mount years of expensive litigation and arbitration where the odds are stacked considerably in favor of the PBM. Thank you for your time, and I look forward to answering your questions.
Thank you both. I'm gonna start. I have a question. So one of the things you mentioned was the spread pricing and how that affects. So we banned that in Michigan. Have we seen the results of? I think that was in 22. They passed that. So have we seen the data to support that that's working or that it's not being followed? I'm just curious because I know that is a big piece of it, or that's definitely a talking point that we hear a lot about. And so I just want to know, like, if we're doing something and then we're not enforcing it, we need to know that we're not enforcing it. If we're doing something and it's working, let's look for the next problem that's still causing this issue. So if you could start with kind of explaining that a little bit, I'd appreciate it.
Chairman, members of the committee, yes. So I will not be able to speak directly to what is happening in Michigan, but I can speak directly to what is happening in several states. So the ban on spread pricing started 4 years ago and has been enacted in states like West Virginia and Tennessee, several states, and my board member, Brandy Chain, will even talk about this in some detail. What we have found consistently across the board is that PBMs are not following that law, and they are also not turning all files over to the regulators who are there to assess if they are in compliance with the law. So what we have seen is that it's inconclusive if it's actually saving money because they're just generally not following those laws.
Okay, thank you. We'll maybe have to follow up with some other folks on that. The next question I had was, you mentioned the rebate pass-through as well. So I think it's the big beautiful bill that says that that rebate pass-through has to be 100% now. Have you looked into that or how that could affect a lot of the operational issues that you're running into? So the manufacturer rebates are required to be passed through 100% through the big beautiful bill. And I just wondered if you've had a chance to see, like, is there a implementation timeline, or have you been able to look at what you think that will look like and how it will affect a lot of the problems that are occurring?
I can answer that. Thank you for the question. So ultimately, it comes down to auditing the PBM practices. The question will be answered whenever states or federal programs start to audit and make sure that those laws are being followed. Oftentimes, what we see is that fees that may be retained in the form of spread pricing, they're going to shift them to something else. So it becomes sort of this game of whack-a-mole, where you might fix it over here, but then they're going to shift this fee over here and find a way to make sure that they protect those profit margins.
Okay, so our job is to figure out exactly what's happening because we want to fix a problem. So how, if that's happening, if it's just a cost shift, how do we find that information? Where do we find it? How do we enforce something if we don't know that the rules aren't being followed? What is the appropriate way to find that information? In your opinion?
It would be comprehensive audits where, you are requiring these PBMs to turn over, full records so that auditors, independent auditors, can look at the practices and see where this money is flowing to. And I'll talk a little bit about this in the presentation, but ultimately what's happening, as Monique said, is as states start to audit these programs, they find that PBMs are not always following the laws, and they are especially disadvantaging the small pharmacies. That's where the violations are occurring, is with the small pharmacies.
And if I just may add one thing, so the timing of your question is actually quite perfect because we are into the start of the 9th week of the year, and there have already been a series of audits published just in 2026 where we are seeing a incredibly complacent attitude toward state governments attempting to enforce their own laws. So when we talk about what you are going to be looking for is you're going to be looking for full records turned over. You don't necessarily have to have these be publicly available data, but you will find that when you do this, where you're going to see the resistance will be in the timelines for turning the information over, protests on what type of information to turn over. And so the thing that we are looking at PUT is what is it going to take to be able to just expedite those timelines and be able to get states the information that they need so they can conduct the full audit and just know for themselves if these pharmacy benefit managers are actually following the law.
Okay, I'm going to let some other folks ask questions from it. So Representative Green, if you would like to ask a couple questions.
Thank you, Mr. Chair, and thank you. I'm sorry for my tardiness. Okay, because this is a very complicated, nuanced, and I guess I'm also asking personally because of what I go through as a high prescription user, I guess. So you'd mentioned prior authorizations. And so I don't know a lot about the healthcare industry. So I'm really, and I thank you to the chair because I'm trying to learn about this. But for example, I have a son who has a major medical condition, and it took years to get to the drug that he needed. The doctor knew he needed, but we had to try 5 other things to get there. Is that and I don't know why that happened. I fought a lot. I called people, but I guess I didn't know who they were. So is it highly likely that I was talking to a PBM going through this process?
Chairman, Representative Green, yes. The answer is yes. So what you just described is what's called step therapy, and it is a frustrating and sometimes harmful process for patients and their families. There are lots of reasons why you might have gone through that, but commonly one of the reasons why patients deal with that is because the drug that your son's doctor in this case knows that he needs is not accessible on the formulary, or there has been some requirement put in place that another less expensive drug is required first. But also, sometimes it has to do with the rebates that are associated with the plan formulary. So sometimes what happens is these step therapy protocols are designed according to the rebate. It is a legally allowed kickback, but it is a payment that is made, a commission almost, to the PBM every time that drug is prescribed, and well, not prescribed, I'm sorry, dispensed, every time the drug is dispensed. So it's usually always either a cost consideration, we don't want to pay that much money, you have to try something cheaper first, or it's a profit consideration, we will receive payment if these drugs are used first. If they don't work, then go to this other drug.
Because, and this was when he was a child, and we spent lots of times in the emergency room. And then once he finally got the drug he needed, I can't get it actually locally. I live in a small town, and for a while, Rite Aid closed, and that was the only place that we could get our prescriptions from. And so then I had to do it online, mail ordering, and it has to be very carefully handled because it's refrigerated. And so somebody has to be home to receive the shipment. So it's saved his life though. So we've stayed out of the ER, but I'm just trying to figure out, I guess, is there laws that prevented that, or is that a company policy?
So I cannot speak with certainty to what the Michigan laws are. I can speak with certainty to a similar situation happening in the state of Arizona with a friend of mine. That is almost certainly a policy. So the pharmacy that you're receiving the medication from, that's dispensing it, is likely a PBM-owned affiliated pharmacy. It can be shipped to a location where someone can receive it. In the state of Arizona, where my friend was dealing with this, her son requires a particular medication, a specialty medication, which is extremely expensive and must be refrigerated, and he is in college, and there wasn't anybody to receive his medication at the university or at the apartment complex where he lives. And she went through multiple she's actually someone who works in the industry. She went through multiple calls trying to set this up, and ultimately set it up to be able to have the medication coming from a PBM-owned pharmacy sent to a local community pharmacy who is signing for it and protecting it on behalf of her son. And they are doing this with no payment to themselves. They're simply doing this because this is what community pharmacies do. They are there for their patients. But as far as
you just unlocked a new fear of next year, by the way. But thanks for making me think about that.
Well, the things that we've heard of, we are very aware of the special requirements that are needed for certain medications. I'm in Arizona. I'm in Maricopa County, where in the summer it gets up to 115 degrees. But we've got 4 of the largest PBM mail order pharmacies in the county, which is kind of crazy when you think about what happens when the medication leaves the facility, but that's a different story altogether.
So then, I just, if I may, a follow-up question, then, because like in our community, then how would the local independent pharmacy that we have, and which we end up paying cash for stuff because we've discovered that it's cheaper, and we're blessed that we're able to afford the cash payment, but how would they go? Is there a process that those independent pharmacies can be able, how would I go about having my insurance being accepted by them?
So if it's truly a specialty medication, so it does have to come from a specialty pharmacy. Keep in mind, this is not an FDA designation. Specialty drugs is a label that was made up by pharmacy benefit managers.
Give me an example of what a specialty drug would be.
So let's say something like Enbrel, which is an injectable drug.
Yep.
So the PBM decides that it's a specialty drug. The PBM all PBMs own their own specialty pharmacy. So it is through their quote unquote plan design or plan benefit that they designed that requires that medication to go to a specialty pharmacy, to be dispensed by a specialty pharmacy. So if a local pharmacy wanted to become a specialty pharmacy, they do have to go through a different licensing structure. A lot of times, and this is where it's interesting, so a lot of times a PBM will allow that drug to be filled once or twice at a local pharmacy, and then after that, it has to go to a specialty mail order pharmacy, which it begs the question of, is it really a specialty drug? Because if it requires so much special handling, then how is it that a local pharmacy is allowed to dispense it at all? And I think it answers the question itself as well, that the PBM or the specialty pharmacy that's owned by the PBM retains a much higher profit margin when they fill that drug.
Okay, thank you.
Representative McDonald?
I understand. Thank you for your testimony today, and thank you, Chair. I understand that Illinois banned step therapy in 2024. Is it too early to tell if that's going well, if that's helping prices?
I don't know if they've actually done a full audit of those PBMs that fell under that law. I think that so step therapy is determined by what's called it's a therapeutics committee on the PBMs. And so here's another really interesting situation. So you might have PBM A over here that designs step therapy, saying that we've determined that this drug is the most effective for this disease state. And then you have PBM B over here that says, okay, but we've determined that this drug is the most effective for this disease state. So keep in mind, those drugs that they've chosen to be the chosen drug most often are tied to a high rebate ticket. Then you will see maybe a year later, a couple of years later, all of a sudden, PBM B now determines that that drug that was on PBM A's preferred formulary or requirement, now they've chosen, no, this is the best one. And you start to see these games switching, between these preferred formularies when really it's tied to the profit margins that they can retain from these kickback structures. So in terms of Illinois, I think it may be a little too early to tell, but the story patients most certainly are benefiting the most whenever these step therapy requirements go away.
And a question, and maybe you answered this, and I'm sorry if I missed it, and it's pretty dense material, but are pharmaceutical companies pretty separate from this? Is this gamesmanship after the fact of pharmaceuticals have been produced, and then it's all in the hands of the pharmacies, and that's where all of these...
Representative, I apologize. Are you asking about the manufacturers
Yes.
as being part of this?
Yes, are they part of this problem, or are they also fighting it?
Okay. That is such a good question. And no one here is an apologist for any member of the supply chain, but what we have found after doing this PUD has been around for 15 years, and I've been doing this solidly for 10, is that the manufacturers are in a very difficult position. So there's something called the net price, and then there's something called the list price. And it's the list price is sort of like the MSRP on a car. It's it's a thought, but it's not what you're ultimately gonna end up paying ideally. Manufacturers end up being in a situation where, because they end up paying out rebates, because they end up paying out fees, those end up getting baked back into the price, which causes a list price to escalate year over year over year. And it sounds bad. It sounds like, oh, greedy pharma. But remember, they retain the net price. All of that other extra is going some other place. And so that's what puts it in an interesting position. So you could say, well, are they complicit because they're adding the rebates into the list price? I mean, I think that's a subjective determination. But to have the medication, I mean, they are producing it. They are the ones that, have to figure out how to factor these other costs back in. So it's sort of a yes and no answer, if you will.
Thank you.
Okay. I think we're going to hold on questions for a second. If you'd like to start with your PowerPoint. Thank you.
Good morning, Chairman Bierlein, even though we've already spoken. Vice chairs, committee members, my name is Brandy Chain. I'm an independent pharmacy owner from Weatherford, Texas. In addition to serving on the American Pharmacies Advisory Committee, Texas Pharmacy Association Public Policy Council, and a member of the Executive Board of Directors for Pharmacists United for Truth and Transparency. I appreciate the opportunity to speak with you today. So what I want to talk to you about is not a partisan issue. It's not a theoretical reimbursement discussion. It's a structural problem in how pharmacy benefits are administered and how that structure is affecting independent pharmacies here in Michigan. So this conversation ultimately comes down to these core issues: access, reimbursement, transparency, and enforcement. I've heard of a current initiative called HEAT in Michigan, and that actually goes hand in hand with the needs of your local independent pharmacies. So let's start with a basic truth that a lot of people don't know. Pharmacies do not set drug prices. We do not design formularies. We do not determine reimbursement formulas. We do not control networks. Pharmacy benefit managers, or PBMs, do. PBMs sit between the health plan and the pharmacy. They decide what pharmacies are paid. They decide which drugs are preferred. They decide which pharmacies are in network. And in many cases, they are vertically integrated, meaning they also own or are affiliated with pharmacies themselves. This same PBM decides how much its competitor will be paid for a prescription claim. So imagine running a business where someone else decides what you're paid, and that someone is actually your competitor. And that decision is made after you've already purchased your inventory. That's the model independent pharmacies operate under. Pharmacies cannot negotiate PBM contracts, regardless of what claims are made publicly or privately by PBMs. The contracts offered to pharmacies are take-it-or-leave-it contracts of adhesion. If a pharmacy opts not to participate in a contract offered by a PBM, they are choosing to turn away those patients and lose what can amount to a sizable percentage of their business. PBMs are fully aware that their contract offerings often force a pharmacy to accept a payment that will not cover the cost of the medications they dispense. So it really brings into the question the business ethics of these massive corporations. What is not in question in Michigan is the value of independent pharmacies, who often have deep-rooted ties to their communities, have established relationships with local providers, and both business and healthcare anchors in their communities. Independent pharmacists are well known for their ability to quickly problem solve, in addition to being the local healthcare provider who stays late, opens early, delivers a medication to a patient's home, follows the problem through until resolved, and knows a patient and their pharmacy well enough to know when something isn't quite right. That's not something that can be accomplished through mail order or chain pharmacies when patients become a revenue line on an earnings chart. So the financial pressures faced by independent pharmacies are most often completely out of their control. When a competitor decides how much you make, what you can dispense, and what patients you can serve, it becomes a matter of simply trying to survive in an environment that is skewed to disadvantage the small local business. Predatory audits that impose penalties for silly things like clerical errors, where a PBM recoups the entire amount originally paid to a pharmacy. Retroactive adjustments that a pharmacy cannot anticipate or track that are based on whether a patient exercises their own free will to take a medication or not take a medication. Steering tactics that push patients away from their local pharmacy, like allowing 2 fills at a local pharmacy, but then subsequent fills must take place through mail order or their own vertically integrated pharmacy. And when questioned, they say it is the plan sponsor's choice or plan design, but remember, it's the PBM that's designing the plan. So now let's talk about the cost to dispense. So cost to dispense is not profit. It is the cost required to safely fill a prescription: a pharmacist's salary, technician support, liability insurance, software systems, regulatory compliance, rent, utilities, inventory, counseling time. Pharmacies are not allowed to balance bill like you might hear about at clinics where a patient must pay what the insurance doesn't cover. Our contracts require an agreement that we will not charge a patient more than the copay their PBM determines, at the time the medication is dispensed. So if a pharmacy is paid less than the cost of the medication and a dispensing fee of, say, 5 cents, it's like the pharmacy paid for the medication, put it on their shelf, they processed the claim, put it in a bottle, labeled it, counseled the patient, and then at the register, they handed the patient a $20 bill along with their receipt. So Michigan's Medicaid professional dispensing fee sits around $10 to $11 for most traditional drugs, roughly $20 for specialty medications. That fee is meant to approximate the professional cost of dispensing. Those dispensing fees are not set because someone decided to be generous or pad the pockets of pharmacies caring for Michigan Medicaid patients. It is tied to actual costs that are real and necessary to ensure those pharmacies can continue to serve those patients. But in the commercial market and in certain federal programs, reimbursement often does not reliably cover cost plus cost to dispense. Dispensing fees provided through a PBM contract are often less than $1, and in some cases, they're zero or simply a nickel. That means pharmacies are sometimes paid less than what the drug cost them before they ever even factor in overhead and labor.
Can I stop you for a second? I'm sorry, because we were right on the slide with, that's the Michigan Medicaid non-specialty rate. My understanding was in 2023, there was extra reimbursement given to rural, smaller scale pharmacies for Medicaid managed plans.
Correct.
Are you saying that is still not covering the cost of dispensing the drug?
So Medicaid, it was only applied to Medicaid.
Okay.
So where pharmacies are really filling this are especially in the commercial market.
Okay, but the previous slide though was showing Michigan Medicaid non-specialty fee, and so I want to make sure I understand. Like, even with the guaranteed extra reimbursement from the 23 law, it's not covering the cost of dispensing the drug.
So there was actually a national cost to dispense study done. The last one I believe was 2018. Let's see. That approximated the cost to dispense. Let's see, I think we have it in here. Approximated the cost to dispense at $12.40. So what I would say is what Michigan did is fantastic. And I think that you should certainly examine if that does actually cover the cost to dispense in Medicaid for the state of Michigan.
Okay, I'm sorry for interrupting. Please continue.
No problem. Okay. So if a pharmacy buys a medication for $50 and they're paid a total of $47, that's a loss before a single staff member is paid. So multiply that across hundreds of prescriptions per week. No business model can survive that long term. So let's talk about what's happening in Michigan. So Michigan has seen a significant reduction in pharmacy locations over the past several years. From January 2020 to August 2024, independent pharmacies declined from 1,026 to 702 as documented by the state. Some of that has been driven by chain closures, but make no mistake, independent pharmacies have also been closing steadily under reimbursement pressure. When a pharmacy closes, it is not simply a storefront vacancy. It is medication access reduced. In rural communities, patients drive farther. Urban, underserved communities, patients lose walkable access. Medication adherence drops, emergency room utilization increases. When we talk about pharmacy closures, we're talking about access to primary healthcare infrastructure. Because for many patients, especially seniors and Medicaid beneficiaries, the pharmacist is the most accessible healthcare provider they see regularly. So this is not isolated to Michigan. Nationally, independent pharmacies have been closing at a rate that averages roughly 1 per day in recent years. And the pattern is consistent across states. The common denominator is reimbursement pressure combined with PBM consolidation. So let's talk about one of the clearest examples of structural disparity, and that is in TRICARE. TRICARE serves active duty military members, retirees, veterans. I bring this up because it's a really good example of what can and will happen. So under TRICARE's pharmacy benefit design, community pharmacies are systematically reimbursed significantly lower than what large chain pharmacies are paid or PBM affiliated pharmacies. For example, same drug, same patient, same federal dollars. This is just a small example of the different reimbursement rates based on where the prescription is filled. So this is absolutely not competition based on free market principles or services delivered. This is vertical integration, creating payment disparity and a choice made by the PBM to pay a local pharmacy less for the same service.
Can I ask, so where do you generate these numbers?
So this comes directly from the patient pricing.
I couldn't hear you.
This comes directly from the TRICARE patient pricing portal.
Okay, thank you.
So the vertical integration creates payment disparity and a choice made by the PBM to pay a local pharmacy less for the same service. Again, one entity designs the benefit, sets the reimbursement, owns the dispensing channel, and the incentive alignment becomes very clear. Independent pharmacies cannot compete against a reimbursement structure that is not equal. TRICARE is a federal example, but the structural design mirrors what we see in the commercial market. So I want to flip to some of the audit findings that we spoke about earlier. So these audit findings demonstrate these realities. This is hard evidence provided by state entities responsible for enforcement. West Virginia released a state audit of one of its PBMs. The audit documented gross violations of state law. The PBM, Navitus, failed to reimburse West Virginia pharmacies at NADAC plus the required 1049 professional dispensing fee, resulting in underpayment of over 46,000 claims. Affiliated pharmacies were paid more than non-affiliated pharmacies for the same drug, including specialty drug claims where affiliated pharmacies were paid higher. Navitus failed to pass through 100% of rebates as required under West Virginia law. Approximately $540,000 in rebate funds were retained for administrative services rather than fully passed through. When Navitus audited local pharmacies, they failed to allow the pharmacies the full 30 days to respond. They imposed documentation requirements more restrictive than permitted by law. They improperly included dispensing fees in overpayment recoupments. Navitus imposed accreditation requirements on specialty pharmacies as a condition of network participation that were more restrictive than permitted by law. So in short, the state found that Navitus failed to follow West Virginia reimbursement floor requirements, failed to fully pass through rebates, treated affiliated pharmacies more favorably than non-affiliated pharmacies, and conducted audits in ways inconsistent with the West Virginia law. These audit findings demonstrate why oversight and enforcement is vital to governing PBM practices. PBMs consistently demonstrate they can and will violate state laws until they are adequately regulated. Let's go to the Tennessee audit. So Tennessee conducted audits examining PBM practices of Caremark. So they found 4 key violations. First, it found non-dispensing fee compliance. PBM failed to properly pay Tennessee's pharmacies' enhanced professional dispensing fee to low eligible pharmacies on numerous claims. Some cases, no dispensing fee at all was paid. They also found delays in implementing the enhanced fee after pharmacies were certified as being eligible. The audit also identified differential reimbursement between affiliated, non-affiliated pharmacies. They documented hundreds of medications where PBMs paid its affiliated retail, mail order, or specialty pharmacies more than non-affiliated pharmacies for the exact same drugs. The Tennessee law requires equivalent reimbursement, and the audit concluded the standard was not consistently met. They also found spread pricing violations, where the PBM charged the plan sponsors more than it reimbursed the pharmacies for dispensing those same drugs. The law prohibits this type of spread pricing, and the audit found instances where those requirements were not followed. So fourth, they identified problems in the appeal process. Pharmacies were not given the full statutory time to respond to claim denials. Some cases, payments following appeals were not issued within required timeframes. So these were also situations where pharmacies were not reimbursed at least their actual acquisition cost. So the Tennessee audit also noted transparency and administrative concerns, including delays in providing requested claims to regulators and unclear requirements for appeals. So again, when multiple states independently find similar patterns like lack of transparency, spread pricing, payment disparities, that's a signal that this is a structural issue. PBMs regularly make claims that independent pharmacies are important healthcare partners and often paid higher than affiliated or chain pharmacies. However, history shows this is simply not the case. When reimbursements fall below the cost to purchase medications and dispensing fees are nominal, pharmacies cannot survive. So now I want to bring this back to some plain language to think about. So a pharmacy orders a medication, they fill it, counsel the patient, they bill the PBM. Weeks later, reimbursement arrives that is below that cost to purchase and below the cost to dispense. The pharmacy has no ability to negotiate, no ability to adjust the price, and limited ability to refuse participation if it wants to continue serving those patients. If reimbursement is below cost long enough, the outcome's predictable. It's closure. When PBMs reimburse pharmacies differently, whether directly or through network design, the independent pharmacy is competing in a system where its ability to operate is controlled by its competitor. This is not a free market dynamic. Conversations like this are not about windfall profits for pharmacies. It is about reimbursement floors that reflect acquisition cost plus a professional dispensing fee. If reimbursement reliably covers drug acquisition cost and dispensing fee, that reflects actual operating costs. Pharmacies can compete on service, efficiency, innovation. If it does not, closures accelerate. Once access is gone, rebuilding that infrastructure is extraordinarily difficult. You can't reopen a pharmacy overnight. You can't instantly restore trust or workforce. Healthcare deserts expand quickly and shrink slowly. So what can you guys focus on evaluating? So you can start to evaluate whether reimbursement models actually reflect transparent benchmarks like NADAC, National Acquisition Cost. It's a publicly available benchmark on what the national average to acquire a medication is. You can evaluate and then include a defined professional dispensing fee. Prohibit self-preferencing within vertically integrated structures, otherwise called steering. Strengthen audit authority and transparency requirements. Ensure regulatory bodies like Department of Insurance or State Board of Pharmacy have been adequately equipped with enforcement powers to ensure your state laws are followed. Those are policy levers. But underneath those levers is a simpler question. Should pharmacies be reimbursed at or above cost required to safely dispense medications? States like Arkansas and Tennessee have taken bold steps to address vertical integration and market consolidation. Arkansas passed a law that prohibits a pharmacy from being licensed if it has common ownership with the PBM. Tennessee just introduced similar legislation. You have states like West Virginia, Indiana, Louisiana, Montana, North Carolina, Iowa, Kentucky, New Mexico. They've all successfully passed laws requiring reimbursement based on a national benchmark or actual acquisition costs, plus an appropriate dispensing fee in commercial markets. So pharmacies are not asking to set the prices, they're not asking for guaranteed profits, and they're certainly not asking for PBMs to be eliminated. Pharmacies are asking for transparency, enforcement, and reimbursement models that reflect real cost, for competitive neutrality between affiliated and non-affiliated pharmacies. When independent pharmacies close, the immediate impact is felt in your districts by seniors, hospice families, rural areas, because their local pharmacist they rely on is gone. This is happening in real time right here. So in closing, just to take a page from the speaker's book, I think it's time to turn up the heat on the PBMs. And I'm happy to take any questions.
Okay, I have a couple. So I'm going to start with the first one. You said that reimbursement rates cannot be negotiated. I thought that was the purpose of the PSAOs. So can you explain that for me?
So-
I'm sorry, Pharmacy Services Administrative Organization. So if you
Correct.
could tell us quickly what that is,
Sure.
and then what their purpose is.
So it's a really interesting tactic that's come up recently that PBMs are pushing, saying that pharmacies can negotiate through their PSAOs. In actuality, that's not true. So PSAOs function on what's called a messenger model. So essentially what happens is a PSAO, pharmacies sign up because it helps them understand what these contracts mean or what's in these contracts, but they can't actually negotiate on behalf of pharmacies these contracted rates. They are simply messengers for the contracted rates that are passed through. I'm definitely not an expert on the messenger model. There are certainly better experts to speak to that, but they cannot negotiate on behalf of hundreds or thousands of pharmacies because they're not under common ownership. So they're essentially just functioning under a messenger model. They're just passing through the offered rates.
Okay.
Let me just also add,
Yeah.
so a pharmacy that may not use a PSAO, that contracts directly with a PBM, there are hundreds and hundreds, thousands even examples where a pharmacy reaches out to a PBM and says, I need a better rate on this. Like, this is not covering my cost. And the answer is always, these rates are final and non-negotiable.
Okay. I want to jump to the slide on Tennessee. The audit was as of 2024. Do you know when the law requiring the audit, so how long had that been the law before the audit was conducted to look for the challenges that they were having?
I am not certain of the year, but I can definitely get that information to you.
Do you know if the results of the audit have led to any internal changes for the PBMs in question?
Those results were just released within the last couple of weeks. So
Okay.
while it covered the time period of 2024, it was just released.
Okay. I think my last question has to do, so this slide, so reimbursements, so acquisition plus service costs, like is that a policy position that we should be pushing? Is that explain that to me?
Sure.
And then how does that work?
So whenever you talk about, oftentimes you'll hear it called a reimbursement floor, where essentially it says a PBM must pay a pharmacy at least their cost to purchase a medication. Oftentimes it's tied to NADAC. And because that's a national average cost for a medication. So it's a really easy way to create policy around that says you have to pay this pharmacy at least what they paid to purchase a medication and then a professional dispensing fee on top of that. So that's where when you hear reimbursement floor, so it's talking about the minimum amount that can be paid to the pharmacy.
Okay, so the minimum amount is based off of NADAC, but that's not necessarily acquisition cost.
Not necessarily.
So if we were looking for policy, would acquisition cost plus a dispensing fee, should that be a starting point? Should that be the policy we're looking for?
Sure, that's what Tennessee did, was actual acquisition cost.
Okay. And again, there's no policy in front of us. This is
Sure.
question and answer right now, but okay. Thank you. Other question? Representative Green?
Well, and I'm going back to that TRICARE on page 9, and I'm trying to wrap my brain. Well, because I have TRICARE. Everybody knows I'm retired military, so I'm still. And that would make sense why an independent. Well, first they said they weren't contracted, so they could never. They didn't have the contract. They won't even TRICARE won't even talk to them, like, period. And I know that's not, like, Michigan's, like, a lot of people here in Michigan, but, because it's a federal thing. But how does that happen? Like, I'm just looking at these drugs, and I don't, like, I don't even know how to say Droxapoda, 90-day supply, which usually you can't get at retail. I have to go to, I can't get I can only get a 30-day supply if I go retail. I can't get a 90-day supply. But it's $89, and it makes, okay, I can see 128, but then how does, like, the grocer get $2,524.78? Like, what mechanism triggered that?
That would be a question for Express Scripts. It's a great question. I mean, it's very curious to see, and you as a TRICARE recipient, you could go online and look at all of this yourself in your patient portal.
Because I have to pay a percentage of that too. And so my percentage then is I have to pay the percentage. Do I have to pay the percentage that got paid to the grocer, or do I get paid? Because then I'm going to want to, because you want to go then somewhere else where you can get it cheaper too. But
it begs the question, and it's just another example of sort of these games. But a really cheap blood pressure medication, a patient would get it through mail order for 90 days, and they would pay $14. But if they were to get it at a local pharmacy, their copay would be 84 cents.
well, and sometimes I get it free, and then sometimes I have to pay $50. So thank
So-
you, Chair.
Okay.
Representative, we, just with respect to your question, we're so limited on time today, but we have, with many of these questions, we have so much information. We would be happy to answer that or email you with additional information on some of the things you're talking about, because in some ways it's very simple, but it's also very complex. We've been engaged in an extensive campaign for the better part of a year now, exactly on the kinds of questions you're asking, getting the answers to that.
Seeing no other questions, I want to thank you both for your time. We're gonna move on to, we have two more testifiers that we're gonna try to get through in 17 minutes. So, thank you both.
Thank you.
So next we have Kyle Brotherton. Kyle is an independent pharmacy owner representing Our Family Pharmacy in Clio. Kyle, thank you for being here. When you have a seat, push the red button, your mic will come on, and we're ready to hear what you have to say.
Good afternoon. Chair and members of the subcommittee, thank you for the opportunity to testify today. My name is Kyle Brotherton, and I'm a pharmacist and independent pharmacy owner in Clio, Michigan. I appreciate that this is a fact-finding hearing. My goal is to explain how PBMs function within the drug supply chain and how current contracting and reimbursement structures directly affect patient access, patient safety, and the sustainability of pharmacy care in Michigan. How the prescription drug supply chain works. To understand this, it is important to understand how the drug supply chain operates. Manufacturers produce medications, wholesalers purchase those medications and then distribute them to pharmacies. Pharmacies purchase inventory from wholesalers and dispense medications to patients. Health plans and employers provide prescription benefits to patients. Pharmacy benefit managers, PBMs, administer prescription benefits on behalf of the health plans. PBMs sit in the middle of the financial transaction. They design formularies, negotiate rebates with manufacturers, determine which pharmacies are in network, set reimbursement rates, process and adjudicate claims, conduct audits. Pharmacies do not negotiate reimbursements directly with insurance carrier. Reimbursement is dictated through PBM contract terms. These contracts are generally standardized, non-negotiable agreements. Vertical integration and market leverage. Today, the dominant PBMs include CVS Health, which operates CVS Caremark and owns Aetna and CVS retail pharmacies. Express Scripts, owned by Cigna. OptumRx, part of the United Health Group. In Michigan, Blue Cross Blue Shields of Michigan utilizes OptumRx as its PBM partner for many of its commercial and Medicare plans. These vertically integrated systems allow the same corporate family to design the benefit, control reimbursement, determine network participation, influence patient direction, and in some cases, operate competing pharmacy channels such as brick and mortar pharmacies, mail order pharmacies, and specialty pharmacies. In the first 2 months of 2026 alone, my prescription count at my pharmacy is down more than 1,200 prescriptions due to steering tactics toward mail order pharmacies. When the entity designing the benefit also controls the reimbursement and competes in the marketplace, independent pharmacies operate within the rules set by their competitors. Understanding that structure is central to understanding the pressure being placed on local pharmacies. 2 pillars of pharmacy viability. From both a public health and operational standpoint, 2 pillars determine whether pharmacies remain viable. Access, the ability to treat patients, and sustainability, the ability to be paid fairly. If either pillar fails, patient access and patient safety are affected. Access and public health impact. Access barriers include initial contracting denials, preferred and closed networks, at-will contracts allowing termination without cause, forced mail order transitions, steering to PBM-owned pharmacies. When pharmacies are excluded from networks, patients must transfer prescriptions, travel longer distances, navigate unfamiliar systems, and reestablish clinical relationships. For elderly patients, rural communities, and individuals managing chronic disease, disruption in pharmacy access increase the risk of medication non-adherence, therapy delays, drug therapy interruptions, increased emergency department visits, and hospitalizations. Pharmacy access is a public health issue. Reimbursement and public and patient safety. Reimbursement must meet a basic safety principle. Providers must not be paid below the acquisition cost of the drug, plus a reasonable professional dispensing fee. When reimbursement falls below cost, staffing levels are reduced, pharmacist workload increases, technician hours are cut, time available for counseling and drug utilization reviews declines, and pharmacy hours of operation are reduced. We have had to make the difficult decision to reduce our hours to manage cash flow. Over the past several years, we have gone from being open 54 hours per week to 45 hours per week. Safe dispensing requires clinical review, patient counseling, drug interaction monitoring, error prevention safeguards. These safety functions require adequate staffing and resources. Reimbursement compression directly affects patient safety infrastructure. This is not simply a business margin issue. It is a patient safety issue. Financial reality. Let me provide a consistent financial data from the past 2 years at my independent pharmacy in Clio. In 2024, we dispensed 51,800 prescriptions. And then this resulted in $1.8 million in total revenue. And that revenue consisted of insurance reimbursement, co-pay and cash payments, and wholesaler rebates. We had a $1.3 million in acquisition cost, leaving us $9.63 gross margin per prescription. 15.5% of those 51,800 prescriptions were reimbursed below cost. In 2025, we dispensed 57,500 prescriptions, resulted in $2.3 million in total revenue, with $1.75 million in acquisition costs, leaving $9.43 as our gross margin per prescription. 10.6% of the 57,500 prescriptions were reimbursed below cost. Meanwhile, the national cost of dispensing reached approximately $15 per prescription in 2024, up from $13.67 in 2023, and is expected to increase further according to the 2025 NCPA Digest. If it costs approximately $15 to safely dispense a prescription and the available margin is approximately $9, the math does not work. For comparison, Michigan Medicaid has set a minimum dispensing fee of $10.80 per prescription. So the volume increased, the revenue increased, hours of operation decreased, margin did not improve. This reflects structural reimbursement pressure, not inefficiency. Reimbursement and predictability and stability. A shift toward NADAC plus a professional dispensing fee would provide transparency, predictability, stability across Medicaid, commercial, and Medicare markets. For clarity, NADAC stands for National Average Drug Acquisition Cost. It is a pricing benchmark. It is published by CMS, Centers for Medicare and Medicaid Services, based on a national survey of what pharmacies actually pay wholesalers for medications. In simple terms, NADAC represents the average invoice price that pharmacies pay to acquire a drug from a wholesaler. It is updated regularly and reflects real acquisition costs reported by pharmacies. Under a NADAC plus model, the drug is reimbursed at its acquisition cost, NADAC, and the professional dispensing fee covers the cost of safely dispensing the medication. The acquisition cost covers the product, the dispensing fee covers the professional service. Predictable reimbursement allows pharmacies to maintain adequate staffing, invest in safety systems, plan inventory responsibly, continuing serving rural and underserved communities, and maintain or expand hours of operation. So areas for continued fact finding. The committee may also wish to examine spread pricing models, rebate transparency, audit standards, copay misalignment, data used for patient redirection. Each of these structural mechanisms influence competition, sustainability, and ultimate patient access. 3 core reform principles. Meaningful PBM reform should focus on transparency, fair reimbursement, and patient choice. PBM should function as administrators of pharmacy benefits, not vertically integrated entities influencing pricing, network participation, and patient direction. In closing, members of the subcommittee, this is not about protecting a business model. It's about understanding where our healthcare dollars are going, protecting patient access and patient safety in communities across Michigan. Local pharmacies are often the most accessible healthcare providers in a community. When reimbursement structures force closures or reduce hours, the impact is not theoretical. It affects seniors managing multiple medications, patients with chronic disease, and families who rely on immediate access to care. If pharmacies cannot contract fairly and cannot be reimbursed at acquisition cost plus a reasonable professional dispensing fee, they will not survive, regardless of how efficiently they operate. When pharmacies close, patients lose access to trusted medication experts, adherence declines, and healthcare costs shift elsewhere in the system. This is not a partisan issue. It's a patient access and a public health issue. Thank you for your time and your leadership on this matter. I am happy to answer any questions.
Thank you, Kyle, for being here. You've reached out. We've talked a few times. Can you talk a little bit about just what you've been doing to try and make your pharmacy viable? So that, because you're the only one left in the community outside of Walmart, if I'm not.
No, we actually have 4 in our community. We have one other independent.
Okay.
We have a Spartan store, and then we have Walmart.
I forgot about the Spartan store.
Which we are a large retired community, a lot of UAW retired teacher retirees. So I mean, we do have a community that can support all of them. But what have I done? Well, I've taken personally a major pay cut. We've reduced the hours. We've tried to find other routes to generate revenue, like our over-the-counter sections. We've become like a gift shop. On Thursday, I'll have my meeting to be certified to do diabetes education, which will be an opportunity to generate non-PBM revenue. We've increased our immunizations by going to businesses, on-site of clinics. Just a lot of things to try to keep the doors open, and hopefully there is some meaningful reform that will allow us to be able to compete on service. And I think if we were to compete on service, it will be hard to beat.
So there have been some law changes in Michigan, and then some recent things at the federal level. Does it come down to the auditing capability to actually, so we say you can't do things, but then are we following up on that? Do you think that's where some of the problem is?
You meaning in regards to the PBMs, or?
Yeah, in that different pricing models, levels, whether the rebates are being passed through, spread pricing, all of those things.
I think it's just the vertical integration. When they control the entire drug supply chain or have their hands all over it, we're the last ones, that sees the customer, and we basically have to take it or leave it. As you can see, that I went from 2024 to 2025, we went from 15.5% to 10.5% of scripts that were dispensed below cost. That's just because I chose not to take certain Medicare plans that were underwater right from the get-go, which again now has forced customers to go elsewhere. Have to drive outside the community because other independents, and even I think one of the chains chose not to take them as well. So just that's going to continue to happen and while this is happening, the PBMs will just gobble up that market share.
Representative McDonald.
Hi, thank you so much for your testimony today. You just mentioned Medicare and that you don't take certain, and it just piqued my interest in terms of Medicare Advantage. Is that problematic in pharmacies?
It's in general Medicare. I mean, we are, like I said, a large Medicare population. I want to say close to 70% of my customers are, Medicare beneficiaries, and that's why you can also see a lot of my script count is down this year because of the steering towards the mail order pharmacies, which are owned by the PBMs. Which is unfortunate because customers come in and they, I'm sorry, I want to use you, but. And like, for example, just the other day I had a customer come in and they were wanting to know why their copay was $60 for the prescription. The drug cost me $64, their copay was $60, the insurance paid nothing. So, I was like, I'm not really sure, you might want to call your insurance. So he called the insurance while I was standing there. And if he were to go through the mail order pharmacy for 90 days, his copay would have been $20. Where 1 month through me was $60. It's not like I had increased the cost of healthcare when I was subsidizing $4 for the cost of the drug. So I think Medicare in general, with the PBMs and their ability to control the drug supply chain, is hurting us.
It's just not fair market practice. It's creating monopolies.
You got it.
Kyle, thank you for being here. We're going to give the last 3 minutes to Brent to come up and
Thank you.
Say what he'd like. So the last testifier is Brent DeArmo. He's the Vice President of Administrative Operations for Hometown Pharmacy. Brent, I'm just going to let you know that in 4 minutes I have to stop this committee by the rules. So that's your time frame. Thank you.
All right, thank you for having me. I'll try and go quickly, real fast. We operate rurally. We have 30 stores in Michigan here, and just wanting to talk on contracting with PBMs. Right off the bat, speaking of PSAOs, they are better reimbursement than directing or contract directing or directly. However, it's still not great rates. Please know that PBMs, unfortunately for us, we are unable to be in a PSAO because of our size. They say that we are technically not independent, even though we're family owned. We operate that way. And at the end of the day, their rates are even worse. So getting towards the contracting issue, there's a whole bunch of different pricing aspects, NADAC, WAC, AWP. Just to give you an idea, one contracting we had this last year, we are down to AWP minus 94%, which means, and they physically told us, they said every year we have to show a further gain for them and a loss for us. They physically told me that. So we're almost to essentially AWP minus 100%, which means we literally will not get reimbursed for the drug, period. And then they play a bunch of different games. So it started with, DIR fees, and now it's transaction fees. And now another game they're playing right now that you might not be aware of is they're auto-enrolling their patients into discount cards, which means that the patient will pay a slightly lower copay, but then the insurance company or the PBMs don't actually have to reimburse us according to our contract because it's through this new discount card. And those fees that the patients pay don't actually go towards their copays, meaning they never hit their essentially their max, out-of-pocket max or anything like that. It doesn't go towards their deductibles. So not only do the pharmacies get less reimbursement because they say, well, it's not part of your contract, they also auto-enroll people to where they never hit their deductibles. So it's double harm on everybody. And I guess, I know I have short time, so I'm sorry, there's a lot, but I'll just try and say this is, I appreciate everyone's time in trying to make this work, but pharmacy is so convoluted because there's a bunch of different players. So I'll just quickly say this. You have the manufacturer, you have the wholesaler, you have the prescriber, you have PBM, you have the plan sponsor, which is like your Blue Cross Blue Shield, and then you have pharmacy. And the question always is, who's left holding the bag? And unfortunately, it's always independent pharmacy, always, because we don't have any options because the plan will just say, well, if you don't like it, don't contract. Don't take the contract. That's fair, right? And the reality is patients are more willing to switch pharmacies than they are to switch insurance plans because most don't have options. And I'll end with this. Mail order is not the solution. I'll say this. You have a sick kid that needs an antibiotic today. Do you know how long that gets turned around in the mail? I'm sorry. Some of these places don't have access, and it's just kids or people or elderly who needs them immediately. You're looking at a minimum of, maybe 5 days at the shortest, and then if there's any type of screw up, they don't care. Good luck getting somebody on the phone. So I'll cut it there, sorry.
Thank you, Brett. I'm sorry that we have to cut you off without questions. I appreciate you driving down. I just want to say, I want to thank everyone who came to testify today, and I want to reiterate that this is not the only meeting we're having. I plan to go over this topic for the next few weeks. There's quite a few people that want to talk, they want to testify, they want to share their perspectives and their stories, and we're just trying to get to the bottom of what this problem is. And so thank you, everyone, again. There being no objection, don't need to do that. Everybody wound up being here. There being no further business before the committee will stand adjourned.